Hello everyone, this is Chadi Alraeis from Digital Medical Center, and I'm delighted to be at SASIS 2024. Now we're going to talk about structural heart disease. I'm really delighted to be with Dr. AlOtaibi and Dr. AlOsaimi. Thanks for joining us. So TAVR is kind of developed now, it's almost 20 years, and we have a lot of technologies happening. And the session today was highlighting some technical aspect of TAVR. But we'd like to know about the program building in Saudi Arabia, and how to put the program together, and patient awareness, and how to funnel these cases to structural programs.
Thank you for having me. These are many questions, but I would say that we have discussed this issue of aortic stenosis many times in many conferences locally, and based on the incidence of aortic stenosis in the general population, we know the Saudis now is getting with better medical care. We have a lot more longer life expectancy, and the average, if you look to the Saudi page on the WHO, you will see that the average age of Saudis is 76.5. So, and we know it's a disease of old age. This doesn't mean that it doesn't happen in the young or middle age. It does happen here, and the incidence of bicuspid aortic stenosis is something like 10 to 15%. So we expected a bimodal sort of incidence when it comes to Saudi Arabia. The young people, 40 to 50, we think of bicuspid etiology, and this is a surgical disease to start with. And with age, it becomes more of senile or age-related. So it's very common. The incidence generally is 2 to 5%. So I calculated personally, or expected, the number of Saudi people, Saudi citizens having aortic stenosis. If we know the percentage of the age in Saudi population, we are dealing with probably something like 4,000 to 8,000 aortic stenosis. TAVR is a very well-established disease, and we adopted this technology a long time ago, more than 10 years, and you know the TAVR started 20 years ago. The first TAVR we did in Saudi Arabia was in Prince Sultan Cardiac Center, and that was done 2009. So at Prince Sultan Cardiac Center, where I work, we celebrated 2 weeks ago doing more than 1,000 TAVR. So we did a quite large number of TAVR. It's an important disease, and we know, I mean the aortic stenosis, we know in addition that aortic stenosis is a time-dependent disease. So those who start symptoms, they have a higher mortality. So that brings to the screening. You were asking about screening. That's why I introduced this, because of the type of questions. So I think we need to have an effective way of screening. And this is probably the main bulk. Majority, I believe, of aortic stenosis, we don't know about them. They are there, they have shortness of breath, they reason the shortness of breath to age or lack of activity, but I think quite substantial of those are having aortic stenosis. If they come to attention, we have a very effective way. We have a referral center, we have many centers around the kingdom doing TAVI, so I think they got referred quickly. So I think the main thing will be how to catch these patients who didn't come to the attention of medical services. But after that, it becomes easy. We practice we can do both surgery, minimally invasive surgery, and then TAVR according to the patient or to the anatomy. And I think this is important. So the problem is, I think, in the screening, in the pre-attention coming to the medical service. After that, you have very effective system of dealing with this patient. Last year, 2023, in Saudi Arabia, there was 800 TAVR was done all over the country. So we have a reasonable number if they come to attention. So it's the screening. I think this is important to stress in the point of screening. We are waiting for the patient to come. I think we should have a way to go to the patient and just to know them before they come.
And that's definitely highlight the importance of primary care, who are really the frontliner. So Dr. AlOsaimi, going to you now, is what do you think now with this, a lot of technology presented at the meeting, So it's a very evolving field, and I think the bread and butter TAVR is we know how to do it. So what are certain techniques that presented about to minimize these complications?
Okay, so like today we had an excellent session on conduction abnormality post TAVR. We had an excellent talk by Prof. Hersey. He's very expert in EP field. I think that the idea is to know your patient very well. It really depends on the baseline ECG, characteristic ECG to begin with, and also the anatomy, the amount of calcification around the valve. And then during the procedure itself, you need to know, again, like it goes, all depends on your CT analysis. You have to look for the calcification, the extension of calcification, membrane symptoms, the length of membrane symptoms, and all of those are criteria that can increase the risk of pacemaker requirement. And of course, the type and platform of the valve they can use. Of course, you have to tailor your valve based on the anatomy of the patient. And with increase the experience of the operator, also the risk will gonna come low and low, and this is very important, especially now with the expansion of TAVR, especially in low risk people and low risk patients, and also younger people. We have to be very careful about the risk of pacemaker implantation. So knowing your patient, your anatomy, select the best valve for the anatomy, all of those are gonna reduce the risk of pacemaker implantation.
So now we know from studies there's a lot of discrepancy or in terms of a misrepresentation of disease in men and women. And as a structural interventional woman cardiologist, do you see the same discrepancy in your practice?
I think we're lacking data on that. I think we need more study to compare the risk, the outcome in women compared to men, especially in the Gulf area. I think this is the future, actually.
Back to you, Dr. AlOtaibi. Now, you mentioned you celebrated 1,000 TAVRs. Congratulations. I had a CTO session before, an endovascular session. Everybody talking about Saudi registry. Is there a plan, or is there something for TAVR or structural heart registry in Saudi Arabia?
We have our own data. These 1,000 patients, we have their data, and happy to tell you that our complication rate matches very well the literature. We have very low mortality, something like 1.5. The risk of stroke is well below 2. So, and the vascular complication, the highest, which is also the highest in the literature, is around 4%. So we have our own data. I think the Ministry of Health should take the lead into, and maybe the National Heart Center should take the lead to get these total data, that database of our TAVR patients. Then I think we can have an important database for the nation. Every center, I'm sure, they have their own database. We have our own database, and it's looking at it, you feel happy that the complication is very low, the success rate is very high. So I think it's an important.
Well, that was a great overview of epidemiology, prevalence, and approach to TAVR in Saudi Arabia. Thank you so much for being with us. And for the viewers, thank you so much for watching SAS Studio. I'm Chadi Alraeis, coming to you from Jeddah, Saudi Arabia. And watch these videos and other on YouTube and other audio channels. Thank you so much for joining us.
Thank you for having me.